On May 22, 2011, an EF5 tornado cut a path 7 miles long and up to a mile wide out of Joplin, Missouri. At the center of one of the most damaging tornadoes in U.S. history was St. John's Mercy, an institution people rely on in times like these. Shelley Hunter was the administrator on call that evening.
I was the administrator on call, so I had gotten 2 calls earlier that day, one that we were preparing for condition gray and then one that we were executing. And I had been watching the weather, so when they told me they were going to execute, I wasn't surprised. It was pretty bad. We knew it was coming. And when they finally got through to me, they were pretty frantic, the operators at the switchboard, and just said, "We've been hit. You need to get here now, and can you get a hold of Gary?" Because they couldn't get a hold of Gary, the CEO.
I came in, got the call actually from Springfield, which I thought was kind of bizarre, but our communications went out so quickly. And it took me about 20 minutes to get to the hospital. I lived just north of the tornado zone. And that was amazing, just getting there and then just pulling up on the rise and seeing the hospital. I just thought there had to be so many people dead and so many of our core workers. You know, that's the kind of stuff going through your mind.
You look up and you look at the hospital, and it was just shocking because you know that we're not going back in there.
I came in the other side of the building and went up the floors to see what was happening with patient evacuation. And again, very businesslike. It was very, I think that training teaches them to just do what you need to do to make sure you take care of patients, and they were all very engaged in that. It was very impressive.
Everybody knew exactly what they were supposed to do, and that really does have to go through practice because it has to be ingrained for you to be able to just kick in automatically without having to have your own personal panic.
I've told people this over and over, and I do believe very strongly that one of the things that made our evacuation so successful was that our staff actually had to physically move people in one of our disaster drills, and they had to bring them down stairwells, and they had to identify where they were going to take them once they got them out of the building. And I think that was helpful.
After the hospital was evacuated, the staff at Mercy were faced with a number of decisions.
There were very, very many decisions that needed to be made. That was the overwhelming feeling that night. For me, was just to think, now how do we get our arms around this? We've gotten our patients safe. How do we find out about all of our coworkers, not just the ones working? We knew that the ones working were safe, but what about all of the others? How can we make sure that they're going to be okay, and what kind of structures can we use? How do we assist the city, in helping the patients that are still out there, the harmed and the injured there? So yeah, that was a bit of the overwhelming piece. We did the best we could. I just know in patients, when we had so many that were critically injured, that we didn't really want to waste the time trying to do all of the paperwork. We wanted to make sure we got them. So literally, as people were coming out my side of the hospital, we were loading a couple on pickup trucks, a couple in SUVs, and just getting them to places where they could get cared for. And we figured that we could follow up with the paperwork after.
No matter how much preparing you do, there's 2 things that are always going to go wrong during a disaster, and that's communication and patient tracking. And so when a response like this takes place, a focus really is trying to mitigate those 2 challenges. And the city did a wonderful job in providing us channels of communication between entities within the city, and our organization did an equally good job. We were challenged locally, as everyone was, by the fact that cell phone coverage was all but eliminated. But we did have 2-way radios, and texting seemed to work. And we utilized a lot of those means. And as far as patient tracking goes, no computer systems, of course, were up and running, and so we did a lot of paper tracking, which took a great deal of effort after the fact, but proved beneficial. In our own organization, of the 183 patients that we evacuated from the hospital, it took less than 48 hours for the organization to identify a final disposition of all of those patients.
With any emergency situation, an incident command is formed. This situation was no different, except for the challenges faced in organizing the incident command team due to the lack of communication.
The biggest challenge that very night was just the communications. None of our radios worked. Our cell phones wouldn't work. That made it very difficult. From a command center basis, what you try to do is set up a base and then get your reports from all the areas. But that night was really frustrating that way, because we'd have a coworker there and we'd say, go to the 7th floor and help us figure out if those patients are evacuated yet. And invariably they'd stop to help people along the way, so you just couldn't find out what really was going on. We had some fire department people show up that actually helped us confirm that areas were cleared out and that we didn't have any patients or other family members up there.
Our normal incident command procedures were gone because we had no, our radios weren't working, the phones weren't working, there was no computers, and so it was mostly EMS radios is the only way that we could get through.
There was initial incident command in the rehab unit where patients had been transferred to initially before they were sent off-site. And the incident command at the rehabilitation unit really helped with that distribution of patients. So it wasn't a true incident command as far as other than just to take care of those patients that needed to be transferred somewhere else that initial night after the tornado. And then the following morning earliest when we established the incident command in Neosho, which is about 25 miles south of here. Because they had access to internet and electricity and telephones and those things you need to begin incident command. Shortly after that, we moved that to the Hammond's Command Center or Convention Center here in Joplin once we were able to secure that location.
So once we had all of our patients evacuated and once we had things stable enough here is when I went over to the City Emergency Operations Center. And so, and really they just wanted to make sure they had a representative. They wanted somebody to be able to speak to how we were doing, how the buildings were doing, and then also just be there to respond to what the needs might be going forward. It was chaos there. It was an amazing night. It was chaotic, but it was also very controlled. It was very impressive how they were so quickly pulling things together from all across the city, from all the devastation.
Due to the amount of destruction to the hospital and the significant number of injuries experienced with this storm, the team in the emergency department knew they were going to need a place to set up and serve patients.
There wasn't a central command that said, take everybody to Memorial Hall and get that going. I think that came from our emergency room staff, who initially were trying to treat patients out just really outside of the emergency room across the street, but realized that wasn't going to work. So somehow they got a hold of the city, and a number of them went by car or some of them by foot, even up to Memorial Hall, and got that set up, just knowing that we would need a place to triage patients and take care of them.
By the time I had seen it, they had lots of patients there that they were taking care of that had been injured in the storm, and they had established communications with the airport for staging patients for transportation either by ground or air ambulance if they needed to be transferred, and were taking care of all the things they could, lacerations and other chronic disease. Had set up a secondary site at Macaulay High School to take more of the patients that just didn't have a place to be and had chronic illness that needed some observation.
As soon as Mercy heard, because we have a regional distribution network that takes care of our Mercy hospitals, it's a Mercy company. As soon as they heard that a tornado had happened, they actually had pre-designed what kind of supplies we'd need, and so that truck was loaded and arrived here about midnight that night. Not because anybody called, but they just knew that we would need supplies, and so they brought those critical supplies, and that was huge for us.
It's at that location that over the course of 24 to 48 hours, we really converted that facility into a small hospital where we designated specific areas of that gymnasium floor to be our supply area, our pharmacy, our laboratory, our x-ray. And really developed different departments, if you will, even though it was all within one open space. We better organized how the treatment areas were established, bringing in partitions for privacy and designating areas that were more specific to acute care versus routine care versus cardiac, and lent what semblance of organization we could to an otherwise non-ideal setting.
Early Monday morning, Mercy's regional office in Springfield sent a team from the Planning, Design, and Construction Department to assess the situation.
By the time we got to the hospital and did a quick walkthrough, the magnitude of the situation had really struck, and I knew we were going to be here for quite some time trying to recover. So our immediate concerns were risk management and risk mitigation.
The first thing we had to do is make absolutely sure there was nobody left in that hospital. So the search and rescue teams came in, and it's a pretty tedious thing to do because you've got to be sure any nook, cranny. I mean, it took a long time to get through the facility.
Our team's job was to analyze what risks do we have to go take care of. So the things that were coming to mind were the MRI machines. There was one in the hospital, one in the MOB. If those things don't have a constant source of power and chilled water, the cryogens charged in the magnet will quench. And if there are people in the building, you could be seriously damaged by those magnets quenching. We had residual power from battery supplies, UPS machines. We weren't sure exactly the status of the city utility feeds or Empire Electric feeds coming into the building. We were concerned with the structural integrity of the building, so our immediate assessments, we wanted to buzz through and look at some critical structural points to see what kind of failures we may have been dealing with.
Then I think security became a huge issue because, we had people trying to get back into the hospital and to the property, and our security team was just not large enough to manage all that.
After the first 24 hours, consisting mostly of risk mitigation, they moved into a second phase of recovery.
There were still some urgent recovery needs that needed to happen at the hospital, things that were in the hospital that we knew we needed to go get out. And we needed to get out immediately. There was data in our computer rooms. There was some backup redundancies between the hospital and the MOB, thinking that we're not going to lose 2 buildings at once. We lost 2 buildings at once. We had to go in and recover that data. There were medical records that needed to be retrieved immediately. There were patients that were receiving chemotherapy treatments on an ongoing basis. Those doctors chart and know, and a lot of our electronic medical records covered a ton of stuff, but there were still some things we really needed to go get.
The one thing I would recommend that we didn't do in disaster planning that would have been nice to know first is to make sure that you know what records you want retrieved, what needs to be recovered, what are your rules and the legal liabilities on recovery of those records, obligations to patients for how long you have to keep those records, whether it's a film, and then have your company picked out and a method already picked out, because that was probably the hardest thing because we didn't have that plan in place before. And although this company is experienced in it, we don't know. They're pulling out records and I'm thinking, I don't know, I don't remember what's in that warehouse. So I am not sure which set of boxes that was. So we probably maybe recovered records that maybe we didn't have to, would have been a little bit of an additional expense that we didn't have to incur. It is kind of expensive. We did ask for testing of records to see how they would come back. I said I didn't want to pay for a bunch of radiology films if they weren't going to be good. So we had that tested and we had the director of radiology view those test documents. Our director of medical records has been very much involved with trying to figure out what records we needed to maintain. And then once you get them cleaned, they freeze dry them, and then they clean them, then you have to figure out where you're going to store them. And that's a whole nother, that's been a process too. Where do we put these records? Do we want them to store them for us? Do we want them to come back here? And so that's probably the one thing I would recommend that we put in disaster planning on the administrative side that we didn't have before.
There was a patient that had a prosthetic leg that was lost in the evacuation. We got the request to go get that. The pathologist showed up, and in the parking lot as we're trying to stage people and assess whether we really needed to go back in this thing as ceilings were still collapsing, glass was falling out of the building, the pathologist came out and grabbed me and said, in the tissue processors in the gross pathology lab, there are biopsies and tissue samples for people that had procedures that we have not analyzed yet. We can't repeat that procedure, and we don't know if these people have cancer. We probably better go get that. So suited up and went in and retrieved those samples. Also Tuesday of managing media, dignitaries, federal agencies, everybody that showed up and wanted to see the hospital. Folks that really needed to see what we were dealing with, but it was very unsafe for us to go walk them through as we were trying to stabilize. So that fell somewhat to my responsibility. As these folks were showing up, we knew we were obligated to show them something, so I got our construction crews to go into the front main door of the hospital with a piece of equipment. We tore out all the doors and storefront, scraped it all out, drove our equipment into the lobby, and cleaned out the whole lobby. We built a wood handrail system through there so we could get people in that front door safely and right back out.
In any disaster situation, there are many financial unknowns. This situation was no different, and the impact of the decisions made could affect the entire city of Joplin.
Mercy that very next day said, we're not only going to be rebuilding this hospital, but we will keep those people employed.
I was at the Department of Health and Human Services in Washington with Mr. Britton, and a person in the audience asked him, when did he make that decision? And he said, well, I actually made that decision that night of the storm. And he said, it became very clear to me that if we were going to have a presence in that community, I had to keep my healthcare workers there. I couldn't let them leave the community. In many disasters in the past, people left the community because they didn't feel they had a job any longer because they didn't have a place to work. So he said, I knew it was very important that I make that decision and I get that information out as quickly as possible. Now understand, a lot of the board members were in Dublin. So he made that decision without even speaking to his board chair. And he said, but I just knew they would be supportive. And I knew that they would want to continue the mission in the Joplin area. And I made the decision because it was the right thing to do. So, that decision, I'm not sure he even recognized would have had such a great impact on Joplin as a whole, on the community of Joplin.
We have a really strong system in the Sisters of Mercy with a lot of really great experts with support. The chief financial officer in St. Louis made the call to not bill the patients. And immediately before, I was still trying to deal with things on the ground, and within the first 2 days, he had made the decision on the not to hold bills, to suspend copays and deductibles, and had a mechanism in place through system in St. Louis to make sure that our coworkers were paid without missing a beat on payroll. So there were several decisions he made in the first 2 days that he made on the fly that were very good decisions that really kept us going. The first week of the disaster in the Memorial Hall, basically what I think of as the emergency department in Memorial Hall, we didn't bill. We didn't have proper billing set up or proper charges to go with the environment we were in. So basically those were free services for that first week. We didn't do any. After that, we didn't send bills out for a while. We did start sending out statements about 45 days after the tornado so people could meet their FEMA deadline for reimbursement on their medical bills. We did not pursue, we stopped all collections. We stopped copays and deductibles at our facilities just to make sure that we weren't adding additional hardships to anyone in the community. In a normal disaster with the financial, there's certain teams. You divide up into teams. There's the clinical team and there's the financial team in the Incident Command Center. And normally we'll try and keep track of any of your disaster supplies, pharmaceuticals, transportation costs, and your patients, because some of that can be reimbursable through state and federal funds or through insurance. So you try and keep those disaster costs separate. Well, that night, there was no way to log supplies. I mean, we had nothing. I was watching physicians take carts of supplies out, and it actually crossed my mind, disaster planning doesn't account for a disaster like this, because you're watching them take all the supplies they can get out of the hospital that aren't damaged to take to Memorial Hall, all of the pharmaceuticals to help not only the patients at Freeman because they weren't prepared for the influx they had, also for Memorial Hall. We were bringing in all the supplies we could, but we weren't logging that or cataloging that. So all we would have had to go on would be basically what was in inventory on May 22nd. And that's how we know what we had in stock. And then we say those are either destroyed, you go back in after, what's left, those are destroyed, or we used it. And so you can kind of track costs that way. Well, all of our property was destroyed. All of there could be liabilities with medical records, which we didn't have much, we didn't have as much as we could have on that. So we're okay there. But there's also, you have the insurance claims, which are property and casualty, but there's also business interruption, where the insurance company will reimburse you for what would have been your profit. But then you have to go, it's a series of calculations, and they will do it on actual, not on real. So there's a lot of calculations and planning that goes into trying to guess what our new businesses are going to be, trying to keep our operations up and going. How do we bill for these patients? Do we have a new set of charges because we're in a different environment? And then you've got FEMA that you have to keep in the loop along the way, even though they're never first dollar. They have to be there and validate along the way with the insurance company. So when they do come in after insurance you can request FEMA funding, they had to have been there along the way. So it's kind of a dual process, even though FEMA's never first dollar. Trying to make sure that we properly account for the write-off of our assets and disposal, debris disposal. So there's a lot of financial aspects that go in, and then trying to make sure, do we bill the patients, for those we had in-house. We made some decisions to suspend copays and deductibles, especially for our coworkers and for our patients, for at least 90 days, because most people in this community were dealing with a disaster on some level, so trying not to put an additional financial hardship on them. There are still, every day, are we making a good financial decision? Some decisions we are making because it's the right thing to do. and they're not good financial decisions. You're making the best financial decision you can given the circumstances.
Because the facilities they were using at Memorial Hall and the tented mobile medical unit were temporary facilities with limited services, they had to be in communication with the Joint Commission and other AHJs to ensure they were maintaining compliance and could bill for their services.
So we had several visits from the state, from Joint Commission. We had to apply for several waivers through CMS to say that we were providing temporary services in a temporary facility. It was not long-term, but we were still meeting all the standards of quality and care in the facility that we had. We weren't going to do any level, we're a level 2 trauma center, so we're not providing level 2 trauma in this facility because we don't have the tools. We will when we're in the interim hospital, but right now we're not. So we applied to CMS. We had to give them a lot of documentation, have some inspections on site, and they did give us a waiver to continue to bill, but we have to continue to contact them every 30 days and let them know where our services are coming, but preferably before, because we can't bill until they give us the green light.
As soon as the tornado had hit, and I think next day we were in communication with Joint Commission. We had tremendous support from Mercy, from our ministry or corporate office, and having those contacts already established. So immediately we began to think about all of the things that when surveyors arrive, not if, but when they arrive, what are they going to be looking for? What are they going to be expecting of us? Truly, it's been amazing how cooperative all the agencies have been. CMS, state, local, Joint Commission have just been tremendous in their support to coworkers and to us. So Joint Commission initially sent a team down several weeks after the storm, but we were in constant contact with them. And so they sent a team from the central office, including George Mills himself, right? The lead life safety guy in my book for Joint Commission. And so it was an honor to meet him, and also very nerve-wracking for our staff knowing that Mr. Mills was coming. But they were tremendously supportive when they were here. They had a checklist that they were going to look, a team of 4. So they had their checklist that they went through, and we had a variety of teams that walked with them through. But more than anything, they were supportive, encouraging, consultative in their visit. The thing that impressed me most about that team was they took an opportunity to speak to our leadership group and felt very much from the heart about taking care of your own, taking care of your coworkers. You all are running on adrenaline now, and you've done a tremendous job in responding. But in the weeks and the months to come, that adrenaline's going to wear off, reality is going to hit, and you need to make sure that you're taking care of each other. And so that I didn't expect to hear that from the surveyors. So that was awesome.
The one thing so many of the employees and staff of Mercy kept repeating was that there is no way to prepare for the complete destruction of your facility.
You know, unfortunately, when we do our planning, we plan it with some, just assuming that some of these things are going to work. So this taught us to plan for the very worst.
I've heard the phrase probably 100 times, there's no book for this. Even when you do an incident plan, disaster planning, you don't ever prepare for your building to go down or to be uninhabitable.
What one was never able to prepare for is a direct hit on the institution that is intended to be there to care for a city when something like this does happen. The destruction of the hospital and the displacement of its co-workers, not only because they no longer had a place to work, but many no longer had a place to live, proved to be an added challenge in how our organization responded to this in collaboration with the community. And yet, with the help and resources of our larger organization in Mercy, we're very proud of how we've been able to contribute to this city and this region's response.